In the second segment on the basal ganglia, let us learn about its connections and clinical significance. Based upon their connections, the basal ganglia are also classified as input nuclei, output nuclei, and intrinsic nuclei which connect the input with the output nuclei. Input nuclei include caudate nucleus, putamen, and nucleus accumbens. All these parts were included under the terminology of striatum. Output nuclei include globus pallidus internum, substantia nigra pars reticulata, and ventral pallidum. Intrinsic nuclei include globus pallidus externum, subthalamic nucleus, and substantia nigra pars compacta. So coming to the afferents to the input nuclei, as we know, input nuclei include caudate nucleus, putamen, and the ventral striatum including the nucleus accumbens. So these parts will receive inputs. Main inputs will be from the cerebral cortex itself. The various parts of the cortices will project to adjacent input nucleus. In addition, the input nuclei will also receive inputs from the thalamus and some parts of the brainstem. So the dorsolateral frontal association cortex as well as the frontal eye field, they will be projecting to dorsal part of the head of caudate nucleus. Orbitofrontal cortex will project to ventral part of the head of caudate nucleus. Parietal lobe will project to body of the caudate nucleus. Occipital and temporal lobes will project to tail of the caudate nucleus. Sensory motor cortices will project to putamen of the lentiform nucleus. The limbic lobe structures and the ventral tegmental areas of the midbrain will project to ventral striatum. So you will see that most of these parts of the input nuclei are receiving input from the adjacent cortical areas. In addition, all these three parts, that is caudate nucleus, putamen, and ventral striatum, will all receive inputs from the substantia nigra pars compacta, which will be getting dopaminergic input, thalamostriate inputs, cholinergic input from nucleus ceruleus, and serotonergic input from the raphe nucleus. Now coming to the various connections, as we have noted, the putamen and caudate nuclei are the input nuclei which are shown in orange color here. Globus pallidus internum and substantia nigra pars reticulata are the output nuclei. They are shown in blue color here. Globus pallidus externum, subthalamic nucleus, and substantia nigra pars compacta shown in violet color. They are the ones which are the intrinsic nuclei. The main inputs to the input nuclei include corticostriate fibers, thalamostriate fibers. Both these are shown in green arrows because they are excitatory glutamatergic inputs. It also receives input from the substantia nigra pars compacta, that is the nigrostriate pathway. These are neuromodulatory fibers which are dopaminergic. Now these dopaminergic fibers are facilitatory to those neurons which have D1 type of receptors on their surface, and they are inhibitory to those neurons which have D2 type of receptors for the dopamine. From the striatum, the output will be to either globus pallidus externum, which is an intrinsic nucleus, or it is to globus pallidus internum and substantia nigra pars reticulata. Both of these are output nuclei. The strio-nigral fibers, that is connecting the striatum with substantia nigra pars reticulata, they are the Coombs bundle fibers which will be passing through the fibers of internal capsule. From the globus pallidus externum, there is inhibitory projection to the subthalamic nucleus. As you noticed, the striatum output is also inhibitory, that is GABAergic, and from the globus pallidus externum also there is a GABAergic output to the subthalamic nucleus. Now subthalamic nucleus on the contrary sends excitatory glutamatergic output to both the output nuclei, that is globus pallidus internum and the substantia nigra pars reticulata. It also sends few fibers back to globus pallidus externum from which it had received the inputs. Now those fibers which connect globus pallidus with the subthalamic nucleus, they form what is known as subthalamic fasciculus. Now these fibers will be passing through the fibers of internal capsule. This part was discussed in detail in the video on subthalamus. Now coming to the output from the output nuclei. The globus pallidus internum and substantia nigra pars reticulata, both of them will send their output to thalamus, mainly to ventral anterior, ventral lateral, and the centromedian part of the intralaminar nuclei within the thalamus. In addition, substantia nigra pars reticulata will also project to superior colliculus in the midbrain, and globus pallidus internum will also project to pedunculopontine nucleus in the midbrain. Now, connection between globus pallidus internum and thalamus, they take one of the following pathways. Either they form fasciculus lenticularis. These are the fibers which will be passing through field H1 of Forel on the dorsal aspect of the subthalamic nucleus and ventral to zona incerta. The second group of fiber bundles are the ansa lenticularis. These fibers will wind round the ventral aspect of internal capsule, and then they will ascend to field H of Forel, where they will be joined by the fibers of fasciculus lenticularis. Finally, these combined fiber bundles of fasciculus lenticularis and ansa lenticularis fibers will pass through field H1 of Forel, where they will be joined by dentitothalamic and rubrothalamic fibers to form what is known as thalamic fasciculus, and finally they reach ventral anterior, ventral lateral, and the centromedian nucleus within the thalamus. So these fiber bundles have been again discussed in detail in our video on subthalamus. You can kindly refer to that video back to revise the structures. So these are the various inputs and outputs to input nuclei, intrinsic nuclei, and the output nuclei of the basal ganglia. So let us now first make sense of these connections. That making sense of these connections is done through these four basic loops of basal ganglia, which include motor loop, which is involved in executing learned movements; cognitive loop, which is involved for motor intentions or for learning any new motor task; limbic loop, which is involved in motor expression of emotions; and oculomotor loop, which is involved in voluntary saccades. So let us find out what are these loops. The motor loop helps in scaling the strength of the movements or organizing the sequences of complex movements through their connection to supplementary motor areas. So it begins from the cerebral cortex in the sensory motor cortex, where the sensory motor cortex, whenever it decides to do an activity, it will send projection to putamen. Putamen will send projection to output nuclei, that is globus pallidus internum and substantia nigra pars reticulata, which will then send output to thalamus, ventrolateral and ventral anterior nucleus, which will project back to supplementary motor area. So this is the motor loop. There are two subparts in it. There is a direct pathway and there is an indirect pathway. So let us find out what they are. Normally, globus pallidus internum is tonically inhibiting thalamus. So this is during the resting condition, globus pallidus internum is tonically active and it will be inhibiting the thalamus, especially the VA, VL and centromedian nucleus within the intralaminar group. Similarly, globus pallidus externum will be tonically inhibiting the subthalamic nucleus. So this is the resting condition. Now when cerebral cortex wants to execute any movement, it will send its output to the striatum. Striatum will take up one of the two pathways. From the striatum, either the inhibitory GABAergic fibers will project to globus pallidus internum directly. So this is the direct pathway. Now here an input nucleus is directly connecting with an output nucleus. Okay, so it's a direct pathway. Once the globus pallidus internum is inhibited by this direct pathway fibers, it will disinhibit thalamus. So then the thalamus will send excitatory fibers to the cerebral cortex that will facilitate wanted movement, any wanted movements, which is the basic intention of the cerebral cortex. Now cerebral cortex will then send information to brainstem or spinal cord through corticospinal or corticonuclear fibers. So this is basically this direct pathway is activated to execute any wanted movements or any appropriate movements. Now this pathway is facilitated by the nigrostriate fiber inputs, which are facilitatory to those neurons which will be having D1 type of receptors on their surface, and those are the neurons which will project to globus pallidus internum. Now back to the tonic inhibition of thalamus by the globus pallidus internum. When the cerebral cortex projects to striatum, there is another pathway which gets activated, that is the indirect pathway, which will be sending basically its inhibitory output to the globus pallidus externum. Now globus pallidus externum is an intrinsic nucleus. So striatum will project to globus pallidus externum. Because this is an inhibitory output, the globus pallidus externum is now inhibited, so it will disinhibit the subthalamic nucleus. Cerebral cortex will also send direct output to the subthalamic nucleus, which is excitatory glutamatergic fibers. So this is known as hyperdirect pathway. So through both these pathways, now the subthalamic nucleus is excited, either through disinhibition from the globus pallidus externum or by direct stimulation from the cerebral cortical input itself. So the subthalamic nucleus will then send excitatory input to the globus pallidus internum. So globus pallidus internum is excited, so it will continue to send the inhibitory output to the thalamus. Therefore, the thalamus will now not be sending any excitatory output to the cerebral cortex, and cerebral cortex similarly will not be sending any excitatory output to the brainstem or spinal cord. So this pathway is active whenever it needs to inhibit unwanted movements. So indirect pathway is involved to inhibit unwanted movements. So basically through direct and indirect pathways, basal ganglia is making sure that only appropriate or wanted movements are executed. The appropriate movements are executed through the activation of direct pathway, and unwanted movements are inhibited through the activation of indirect pathway. Mind you, these two are not exclusive. That is, you don't excite either direct pathway or indirect pathway. They are being done simultaneously. So whenever there is a movement required or movement which is desired, the direct pathway will make sure that those muscles which are required to act will be stimulated so that they will continue to contract and the desired movement is acted upon. Whereas the other muscles which are not required to act at that particular point of time, they will be inhibited to prevent any unwanted movements. So let us find out this pathway in the cerebral cortex here. The direct pathway has 5 set of neurons in its total path. The first set is in the cerebral cortex, second set in the striatum, third set in the globus pallidus internum, fourth set in the thalamus, and fifth set back in the cerebral cortex. So it's a 5-order neuron pathway. Helps in basically stimulating the cerebral cortex so that a wanted movement is executed. On the contrary, an indirect pathway is a 7-order neuron pathway. Starts from cortex to striatum to globus pallidus externum, subthalamic nucleus to globus pallidus internum, and then to thalamus, which will send inhibitory output to the cerebral cortex. So this will be inhibiting the cerebral cortex, resulting in basically preventing unwanted movements. Now coming to the other loops, that is cognitive loop. This helps in motor learning and planning ahead with respect to complex motor intentions. So here we have cerebral cortex, prefrontal cortex, which will be sending its output to caudate nucleus. The caudate nucleus will then send output to the output nuclei, that is globus pallidus internum and substantia nigra pars reticulator, which will then send information to VIII nucleus of the thalamus, which will send information back to the cerebral cortex. Either it reaches prefrontal cortex to close the loop, that is the loop started from prefrontal cortex and it came back to the prefrontal cortex, so that it's a closed loop, or it may reach premotor area, that makes it as an open loop because this is learning new motor activity, so it is reaching the premotor area. So this is the cognitive loop. This loop will be active only when you are learning any new activity, and it will become once the activity is learned properly, then this same activity will be shifted to the regular motor loop. The cognitive loop coming into play only whenever there is a new motor skill being learned. Now coming to the third loop, that is limbic loop. Now this loop is involved in motor expression to the emotions. So basically you're smiling, gesturing, taking some postures like aggressive posturing or submissive posturing in response to some of the emotions. So that is being expressed through the connections to limbic loop. So here the inferior prefrontal cortex will be projecting to ventral striatum, that is nucleus accumbens, which will then project to ventral pallidum, and ventral pallidum will project to MD nucleus or the mediodorsal nucleus of the thalamus, which will then project back to inferior prefrontal cortex. So this is the limbic loop, which will be active whenever you're trying to express emotions through the motor activities like smiling or gesturing. Now coming to the oculomotor loop, the frontal eye field and the posterior parietal cortex, which will be basically the parietal eye field, they will project to caudate nucleus. Caudate nucleus in turn will project to substantia nigra pars reticulata, which is again an output nucleus. This will project to the thalamus, the ventral anterior part of the thalamus, which will project back to frontal eye field and prefrontal cortex. But when this is happening, substantia nigra pars reticulata is again continuously sending inhibitory output to the superior colliculus in the midbrain. So how does this oculomotor loop work? The substantia nigra pars reticulata is tonically inhibiting the superior colliculus. That is what helps in fixation of eyes. For most of your activities, you need to fix your eyes to a particular point of focus. But whenever you want to execute a voluntary saccade, then this oculomotor loop will become activated so that the substantia nigra pars reticulata now will disinhibit the superior colliculus, and then the superior colliculus will send the appropriate inputs to the horizontal and vertical gaze centers, resulting in voluntary saccades. So that is how the oculomotor loop will act. So these are the various connections of the basal ganglia. So we have input nuclei, we have intrinsic nuclei, and we have output nuclei. Now these will be variously connected either through a motor loop, which can be having a direct pathway facilitating movements, or indirect pathway inhibiting unwanted movements, or we will be having activation of the cognitive loop in case of newly learnt activities, or activation of limbic loop to express emotions by motor activities, or activation of oculomotor loop for bringing about voluntary saccades. Now coming to the basal ganglia disorders. They are again divided into three groups: bradykinetic hypertonic disorders, that is where the movements are reduced and muscle tone is increased; dyskinetic hypotonic disorders, here there are unwanted excessive movements but muscle tone will be reduced; or there is dystonia or dystonic disorders, where there is torsional spasm of some of the group of muscles. Under the bradykinetic hypertonic disorders, we have Parkinson's disease. Now this whole set of activity, that is Parkinson's disease, is because of insufficient direct pathway output and excessive indirect pathway output. So both these will result in reducing overall movement, that is why resulting in bradykinesia. Now dyskinetic hypotonic disorders include chorea, athetosis and hemibalismus. Here we are having excessive unwanted movements. So there is an excessive direct pathway output and insufficient indirect pathway output. So there is not much of inhibition of the unwanted movements. So all movements are being brought out in the form of either chorea or athetosis or hemibalismus. So what is this chorea? Chorea is actually, it's an abnormal involuntary movement which almost resembles dance-like movements. They are brief, irregular, unpredictable, jerky movements. They affect either shoulder or hips or even sometimes even face. And usually this is seen in case of atrophy of striatum or loss of striatal GABAergic neurons. So that will be basically resulting in reduced inhibitory output given by the striatum. Now what is athetosis? Athetosis is twisting or writhing movements. So these are basically continuous stream of slow movements which is sometimes even described as squirming movements. They involve limbs, and this is usually as a result of damage to putamen. Balismus, or more often because it is seen on one side, one half of the body, they are called as hemibalismus. These involve violent, flailing, intense movements of either one arm or one leg, seen on the contralateral side as compared to the side of the lesion. Now this is because of the degeneration of subthalamic nucleus, or because of thrombosis of branch of a posterior cerebral artery which will be supplying the subthalamic nucleus, so resulting in hemibalismus movements. Now here the movement will be more proximally seen, that is more in the shoulder or the thigh region, whereas athetosis will be more in the distal limb parts. Now this is because of the excessive, as I said earlier, excessive direct pathway output. So there is happy facilitation of wanted movements, but there is also insufficient indirect pathway output. Therefore, there will be no inhibition of unwanted movement. So we have excessive movements called as dyskinesias. Then there is dystonic disorders. Now, as I said, these are torsional spasm of group of muscles. Here what we find is repetitive twisting movements or a particular posture taken up because of the spasm of some muscles. Some of the syndromes include Meach syndrome, that is the blepharospasm, spasm of the eyelid muscles. Oppenheim's syndrome, that is again spasm of any of the muscles in any part of the body actually, but it is congenital. Torticollis, spasm of the sternocleidomastoid muscle. Spastic dysphonia, laryngeal muscles undergoes hypertonic, or they become dystonic, and that will result in altered sound production. Or writer's cramp, wherein the forearm and hand muscles will undergo dystonia. Often it is found that direct brain stimulation or deep brain stimulation of globus pallidus will result in relief from these symptoms. Then there are some other basal ganglia disorders which include restless leg syndrome. That is because of the decreased iron in substantia nigra pars reticulata, and also reduced D2 receptor binding in striatum. Or there is another condition known as Wilson's disease, which is because of the problem in copper metabolism. Here the basal ganglia involvement is vacuoles in the putamen. And caudate nucleus, if there is injury to caudate nucleus, a person is known to show hyperactivity. And if there is hyperactivity in the caudate nucleus, a person shows this obsessive compulsive disorder features. So caudate nucleus is associated with this OCD features or hyperactivity. And nucleus accumbens is again associated with addictions to various drugs. So these are some of the areas where some interesting work is getting done. Let us, in this particular session, let us know a little bit more about Parkinson's disease. In case of a normal person, when the cerebral cortex sends its output to the striatum, striatum sends inhibitory output through direct pathway to globus pallidus internum, which will disinhibit the thalamus, which will send excitatory output to the cerebral cortex, which facilitates movements, which will be conveyed to brainstem and spinal cord through corticospinal or corticonuclear outputs. Now this direct pathway in a normal person is facilitated by the nigrostriate fibers, because these will be facilitatory to those neurons which are having D1 type of receptors on their surface, and these D1 type of receptor neurons are the ones which are sending their output to globus pallidus internum. Now what happens in case of Parkinsonism is this nigrostriate pathway is blocked. So they do not facilitate the direct pathway, and therefore the globus pallidus internum continues to inhibit the thalamus, and which will then continue to not send excitatory output to the cerebral cortex. So there is inability to initiate movements, resulting in bradykinesia. So that is the basic underlying situation. So what is the main pathophysiology here? There is degeneration of dopaminergic neurons in the substantia nigra pars compacta. So there is reduced nigrostriate output. Within the striatum, there is deficit in dopamine storage and reuptake. If you take a section in the autopsy, or a section of the midbrain in the autopsy, we will also find that the substantia nigra pars compacta will show decreased neuromelanin quantity, and plus whatever remaining neurons will be there, they will show collection of a particular protein which is wrongly packed, known as synuclein protein, forming eosinophilic collections within the cell known as Lewy bodies. So these are the features which are seen in the section of midbrain substantia nigra pars compacta. And what is the overall effect? Overall effect is there is a shift from the direct pathway to the indirect pathway. So normally what pathway would have facilitated movements, that is suppressed. Instead, the suppressive or inhibitory pathway which is executed to the indirect pathway, that is allowed to act excessively, resulting in bradykinesia. So the whole disease lurks on one underlying mechanism, that is degeneration of these dopaminergic neurons, which will be facilitatory to the neurons which will have D1 type of receptors on their surface. Basically those which are involved in direct pathway. So what is the clinical presentation? There is bradykinesia, which will be expressed either in the form of rigidity. The classic type of rigidity seen in case of Parkinsonism is cogwheel rigidity. That is rigidity, release, rigidity, release, rigidity, release whenever you are trying to elicit a particular passive movement. So that's known as cogwheel rigidity. This is in contrast to the clasp knife rigidity which is seen in the case of upper motor neuron lesions. There is also lack of spontaneous movements because of bradykinesia, like you will be swinging your arms when you're walking. That's a part of the movement. You'll be gesturing using your hands when you're talking. These are spontaneous movements. So those will be completely missing in case of a patient of Parkinson's disease. The second feature is hyperkinesia in terms of resting tremors. So the patient will show pill rolling type of movements, usually seen first in one limb, then it will slowly spread to the remaining 3 limbs, one after the other. So these are resting tremors. So when a patient is sitting at rest, he will show these tremors. The minute he begins to act to do something, the tremors will disappear. Again, these have to be contrasted with the tremors in case of cerebellar lesion, wherein they were the intention tremors. So the tremors would be set in when the person would begin to act. Otherwise, during rest, he wouldn't have any tremors in case of cerebellar lesion. Whereas in case of Parkinson's disease is the contrast. In case of a resting condition, the patient will show tremors which are of pill rolling type. It's like small pills being rolled between the fingers. Whereas the minute he begins to act, the tremors will disappear. The third feature is bradyphrenia. Now, bradyphrenia is basically slowing of mental processes. So there is depression and dementia. In fact, this is one of the way in which you set in this particular Parkinson's disease as different from the upper motor neuron or any other paralytic activity. Firstly, there is no paralysis in case of Parkinsonism. Secondly, it is usually associated with slowing of mental processes. Because of this bradykinesia, there will also be affected posture. Usually patient shows stooped posture, and there is also fixity in his muscle activity. So if you ask the person suddenly to turn, his legs go in, they'll be fixed at the same place. So he will fall like a telegraphic pole. So these are the classic features of Parkinson's disease patient. He will also show mask-like facies. His face will be absolutely devoid of expressions. That is because of involvement of limbic loop. We'll talk about it next. There's going to be slow and shuffling gait, which have small steps, and they will be propulsive in nature. That is what is known as marche petite pass. Patient may actually present to you as his first symptom that he has altered handwriting. That is, his letters have become smaller and the letters have become illegible. That is because now his hand movements have also become limited, resulting in smaller handwriting, and slowly it will also become illegible. And patient shows altered speech in terms of a slow, monotonous, slurred speech. So these are all the various clinical presentations of a patient suffering from Parkinson's disease. treatment has been for a long time levodopa, wherein we are trying to give dopamine precursors as supplement because the nigrostride output having gone, the dopamine is being supplemented. That will give relief in the early stages, but in the later stage, the levodopa itself may result in some of the dyskinetic moments. So another way of treating would be surgical treatment, wherein what we currently do is deep brain stimulus of globus pallidus externum or the subthalamic nucleus. These two have found to show in reducing not only the resting tremors, but they will also improve the bradykinesia part. In case of Parkinson's disease, the limbic loop will be affected because that is again loop which is rich in dopaminergic input. Once this loop is affected, that will result in mask-like facies as well as absence of any of these spontaneous gesturing in case of Parkinson's disease. Similarly, oculomotor loop will be also affected. So there is faulty disinhibition of superior colliculus that will be following the degeneration in substantia nigra pars reticulata, which will cause oculomotor hypokinesia. So these are other features as seen in the Parkinsonism. So with this, we come to the end of our session on basal ganglia. Hope you enjoyed this video. You can visit this site for other neuroanatomy videos. Thank you very much. Happy learning.